Thank you, Barb. And again, welcome back to everybody who was here for our AGM and to those of you just joining. Appreciate that you've agreed to spend some time with us this morning. We're thrilled to be able to welcome our presenters today to this session. Each presentation, as Barb said, will be 30 minutes in length. And really, the focus will be highlighting the strong partnerships and innovative solutions that are being developed across the 211 network and across the broader ecosystem. We continue to be inspired by this work happening in many communities across the province, and we want to celebrate that innovation today and hear a little bit more about the work of the future. We'll start off with our first guest, and I would like to introduce to you Shelley Morris from Ontario Health. Shelley is the Director of Patient Access and Navigation in the Population Health and Value-Based Health Systems portfolio. So it's a mouthful, and we do have full bios for each of our presenters, but I don't want to steal any of Shelley's thunder, so I'm going to hand over to her to provide you an overview of what she'll cover today. Thank you for being here, Shelley.
Thanks a lot, Karen, and thanks for having me today. And it's a long title, and I'm glad we don't have business cards anymore, because I think if I had them, they'd look more like rulers than business cards. But it's an important thing we are focusing on with population health and value in the healthcare system. So yeah, with that, I think I will just share my screen and get into the presentation. All right. So again, thanks for having us here today. And Karen and I have had a lot of discussions over the last couple of years about the Health Connect Ontario program and 211 and opportunities with OHTs and how really everything, the HCO program, I laugh sometimes, is like a big octopus. It cuts across and touches all parts of our system. And so the real crux of it is starting to bring things into one place for patients. And so I'm really happy to be here today, and hopefully we have a few minutes, I think, for some question and answer. Just to give you some background on Health Connect Ontario. So the Ministry of Health started the procurement for this back in the fall of 2019. And really what it was enhancing the existing Telehealth Ontario service. So I'm pretty sure everyone's familiar with that. It was the phone line that Ontarians have been able to call for 22 years to talk to a nurse for help with symptoms and sort of navigating the healthcare system in Ontario. So it was a real opportunity to redo the contract and go back to the market to add on and enhance the service and add on some digital options. So that all happened, like I said, starting in 2019, went through a very, very rigorous procurement process. And the contract was awarded to the new vendor back in October of 2021. Oh, sorry, George. I see you've called me out. I need to refrain from using acronyms. So OHT is an Ontario Health Team. So that's the new direction in the province, to work to bring in health service providers in catchment areas, really more of an integrated service delivery model. So we work really closely with the ministry and with the Ontario Health OHT team to look at how HCO can really complement and enable those Ontario health teams with their mandate. So once the contract was awarded to the new vendor, and the new vendor is a consortium, so Orion Health is the prime vendor. St. Elizabeth Health, which I'm sure a lot of folks have heard about, is the clinical arm, and so they operate the call center piece, which is still in operation and will be. Ada Health is a company that has an AI-based symptom assessment tool now that's on the website, and I'll talk about that in a bit. And Think Research is an Ontario-based company that is really looking at the virtual visits component of the service, as well as the health services directory. So the ministry actually led the procurement of this, and they assigned the contract over to Ontario Health to oversee the implementation of the service, as well as the oversight and management of the operations of the service moving forward. But we still have a governance model for Health Connect Ontario that includes the Ministry of Health, and we work with various branches of the Ministry of Health as well on this program, and have actually engaged with MCCSS as well in the past. And so that's the exciting part of being able to present here today, and lots of the conversations Karen and I have been having about how we integrate the community and social services that are addressed by 211 into this service as well. So the vision for Health Connect Ontario, as I mentioned at the beginning, is that this navigation service, this Health Connect Ontario, will become the digital front door for Ontario's healthcare system. So it's offering that one place where Ontarians can go to access health information, advice, symptom assessment, initial triage to help support them to become connected with those publicly funded healthcare services and social and community services, such as their Ontario Health Team, and then also related information and supports through other features to help them through their healthcare journey. So if we look at this diagram, this sort of incorporates all of the pieces of Health Connect Ontario. So if an Ontarian is looking for healthcare advice or just awareness and learning of the healthcare system, clinical triage and advice, and non-clinical advice and services as well, they can either call, we've changed the phone number, so the old 1866, I can never remember the phone number, still is in operation and it will be indefinitely, but we also added in the ability for patients to just call 811, or for Ontarians, I should say, to just call 811, much easier to remember. We've added on a website and the ability to also access the site through a mobile responsive website. So under Health Connect Ontario, there's a lot involved. There's a lot of services that people can access. Symptom checking and health advice, and that can be through the nurse on the phone or through a multi-channel approach with now features that are on the website. There's health education resources available on the website as well as a health services directory. And so there's a real opportunity there. I'm going to talk a little bit about that in a moment. There's also sub-programs that have been in operation by the telehealth program in Ontario for 22 years and, that I didn't even know about before I started working on this project, but there's a lot of services that Ontarians can access through this service. So those include nutrition counseling with a registered dietitian, registration for Healthcare Connect, where patients can go to find a new primary care doctor if they don't have one, smoking cessation with a quit coach through a sort of structured curriculum. There's a telehealth advisory service which works with some of the primary care clinics in the province to provide after-hours coverage. There's a refugee health line for newcomers, connections to mental health and addiction supports like Connex, enhanced breastfeeding support for new moms with lactation consultants, as well as medical assistance in dying care coordination through the service as well, and colorectal cancer screening program for unattached patients in the province that don't have a family doctor that need to be screened for colorectal cancer. So then at the bottom you see that this is where we have a real opportunity, is connecting in with those Ontario Health Team navigation supports. So the OHTs are tasked with providing navigation to their populations as well. And then connecting in with the social and community supports. So this is why we're here today, and making sure that that's seamless as well for Ontarians. And then others. So the nice thing about this, and I'll talk a little bit about that, is that the new contract with the new vendor allows for an annual road mapping process to occur. And we have a little bit of a sort of ceiling allowance of funds to be able to leverage every year to enhance the service, integrate new services, and new features and functions into the digital experience for patients. So that's pretty exciting, because that just means, it's just going to continue to grow and evolve over the years. So how are we going to enhance the digital service experience with HCO? So HCO, as I said before, will become that digital front door. So it's the one place to go. The ministry did a really big patient and caregiver and provider engagement before the before the procurement process was started. And that was the resounding theme of that engagement. We want to go to one place. We're kind of tired of having to go to, all these different websites, all these different phone numbers. We want to have access to all of our health information and social information and support information in one place. So to do that, we've got a lot of existing assets in this province that we can integrate with. One of those is pretty exciting, and this project is just getting started. Karen and I have chatted a little bit about this, but it's called the Provincial Health Services Directory. So that project has actually just gotten approval through the Ontario Health gating structure, and really will look to engage with existing directories in the province, like 211, like Connect's Healthline, to be able to partner and offer sort of a single feed of data from the various different directories in one spot. And there's been some really great work done by some of the Ontario health teams in the province already on this. I know Dave Montague is really involved in that with it's the East York Region North Durham Ontario Health Team, in terms of working with Healthline and Connects to try and create that one spot to search for directory information for services and programs in one website. So lots to be learned from what's been done already in that sense. And it's an exciting opportunity. And for the Provincial Health Services Directory, the timeline is that I met with them yesterday to talk about this because I wanted to be able to speak to it today, is that in the spring, that's when the Provincial Health Services Directory Working Group is planning on doing some engagement with external directories like 211 and Connects and Healthline. So there's lots to happen before that in terms of planning. They call it the plumbing that they've got to build, and that's the infrastructure. So it may happen sooner than that, but I think that's when we actually will get into the nitty-gritty about being able to partner up with the directory providers like yourselves. So the next piece is really providing localized content in health services, and this is where we get to work with the Ontario health teams to say, okay, so if we can tell a person when they sign into this experience, and right now they don't sign in, that's going to be something that is going to be improved upon in the fall. Like Ontarians will actually be able to go to the HCO website and create a profile and log in. Is that when they do that, it'll start to present local contents and services specific to their needs. And so they can set their preferences and it'll know where they are geographically, and it'll start to surface information that's really relevant to that person based on where they are and what they need. That'll be, of course, behind digital identity. So we're just working on implementing the Ontario Trusted Account in order to achieve validation of identity for users that are coming in through the website. And also then integrating with the provincial patient clinical viewer. So that's where, we can actually start to integrate with some of the portals that are the patient portals in Ontario. So people can see what their lab results are, what their, hospital reports say. In the future, it'll be able to show them what medications they are being supported on through some integrations with the Ontario Drug Benefit Program, as well as digital imaging as well. So we'll be able to actually surface radiology reports for patients, and that'll all happen through one place. So that's really exciting because right now people kind of have to go, sometimes they can't even access that information, but they have to go to various different places and create a bunch of different profiles. And so we want to standardize that and put it into one spot. So really what's being explored and planned for next fiscal year, so we kind of soft launched. We transitioned the call center over on April 1st. We had 6 months to do that, so that was a really aggressive and ambitious timeline to be able to do an implementation of this type, but we managed to pull it off with a few extra gray hairs. So we launched the call center transition from the incumbent vendor on April 1st for the telephone nurse triage service. And then on April 21st, we soft launched the website. So right now, you can't actually search for Health Connect Ontario on Google, and that's by design. We wanted to have a little bit of time to be able to, work on some of the things that we did for the first launch on April 21st and enhance and fix some of the things that inevitably in something like this always have to be fixed. So the timeline for that is actually in October, that there's going to be another release to improve upon some of the functionality on the website. And then the Ministry of Health, who leads the communications for this, because they are the face of the service, will actually be doing a bit of a communications campaign to broadly promote the service and then also allow for it to be searched on Google in the October timeframe. So really what we're doing right now is we've gone through a lot of user engagement sessions. So we pulled in folks from various parts, equity and access, Ontario health teams, primary care, mental health and addictions, community services, and I'm probably forgetting a few of the stakeholders that we worked with, but we've had some ideation sessions to start collecting input on the experience, the website and the service, to start thinking about what we can put onto our roadmap for the next 18 months. So a lot of the things that we're going to focus on for the next 6 are really getting those digital service integrations that I mentioned on the previous slide. We're also looking at being able to enable a video visit. So if you can imagine calling, previously you called telehealth, but now you'll call HCO, and the nurse says, you know what, it would really benefit this visit so that if I could see you or your child and be able to do a little bit more of a visual assessment clinically. And I'm a nurse by background, so that's just amazing to me, that they'll be able to actually, and we're figuring out the how of this, start a video visit with you so they can actually see you and do that clinical visual assessment as well. Online appointment booking is something else we're looking at in terms of being able to actually book appointments through the service or through this one place for your care providers. And obviously, that I talked about it earlier, getting that OHT content surfaced, and also we're dealing with planning, or we're in the middle of getting started in it, the fall surge planning. So in anticipation of the flu and COVID season that I think we're starting to see a little bit of an uptick on now. So that always affects the call center in a big way, because a lot of Ontarians use the service to find out what they should do when they're not feeling well. Future opportunities on the right is really sort of high level, but really looking at how we can really leverage that validated user. And then once they sign in, what else can we put there? And how else can we make integrations and warm transfers and seamless connections through this service? And then obviously just continuous improvement in the product and the design and development process. So those ideation sessions and the stakeholder engagement will actually be ongoing for forever, as long as the service is up and running, to be able to continuously improve and enhance the service to meet the needs of Ontarians. And Dana Saunders has joined me today, my colleague. So she's actually going to be working a lot with the various stakeholders in the province to be able to address some of the needs and things that they're servicing. And I'm just seeing some things coming up in the chat, so I can't address that now. Learning how to address linguistic preferences. Yes, so the website is, everything is in French and English. So if you call the call center, if you decide to use any of the features on the website, the whole website you can toggle into French. And actually I had a meeting yesterday where one of the French language entities actually brought up a great point, that there's also we need the ability to be able to point users to French services in Ontario, and so there's some work we can do there. So I'm excited to engage with them to be able to identify how we can work on that. And also we're looking at the opportunity. So there's I think 240 plus language that can be accessed either through the phone line and through, I should have mentioned earlier, there's the chat feature on the website that you can chat live with a navigator or a nurse. And so the nurses there and the navigators, we have the ability to do translation through that vector as well. And looking at opportunities to be able to offer the rest of the website in a multitude of languages. So that's something else that we actually just had a meeting about yesterday. And George, will this replace 211? No, absolutely not. We want to partner with 211 to leverage both the fantastic directory that 211 has, but also the agents in terms of how we can make seamless connections between the HCO staff and the 211 folks as well. So definitely not looking to replace 211 with this service. But great questions. I think that's it. I wanted to keep the slides short and sweet. So I think with that, and I might actually be close to my time. So Karen, is there a question and answer, or is that?
Yeah, no, I think it was. So Shelley, we've got a couple minutes for questions, and maybe, I don't see any in the chat at the moment, but one of them that came up from, as I was listening to you talk, was, have you thought about, or have there been any conversations with the announcement of the 988 service for suicide prevention launching by November of next year? Has there been any initial conversation about how that will align with the new 811 service?
I'm glad you said that, Karen, because you just reminded me I have an email in my inbox from the ministry about 988. So yes, we want to make those integrations and figure out how we transfer. We actually have in the Toronto region worked with the 911 service in Toronto to be able to do warm transfers between HCO and the 911 service in Toronto. So it really helps them if they have a patient with a lower acuity need that maybe they just need a nurse to assess. 911 can actually do a hot transfer over to the HCO service. So there's probably an opportunity with 988, but admittedly, I haven't really learned enough about that, but I think that's a great call out. But that's exactly what we want to be able to do.
Thank you for that, Shelley. I am not seeing any. Oh,
there's one
more
question.
Karen. There is a question, yes. So have you paid particular attention to allow access to the service by Northern and Indigenous communities?
Yes, and that's a fantastic question, Arnie. I am actually from Northwestern Ontario. I was born in Kenora, so this is near and dear to my heart. I'm a nurse by background, and a lot of my nursing colleagues have worked in the Indigenous communities. So we actually are engaging with SE Health, so they're part of the consortium, and they have a First Nations, Inuit, and Métis team that we're working really closely on. And one of the big things that we're going to do in the next 6 months, in the next 18 months, is we have a big discovery piece of work that we're doing with Indigenous communities. So we're partnering right now with the First Nations digital health folks, and we've met with every possible table we can at this point for Indigenous health, and so we're really excited about that. And I know Dana's got a passion for Indigenous community engagements as well, so we're really excited to move forward with that work and see how we can make HCO a better service to address the needs and add value to Indigenous folks, because it's just, we've got to be there with Indigenous communities to understand what their needs are. I've started to look at some of the journey mapping that's out there, and it's amazing that, there's a real, at the provincial level, sometimes we know this, there's a lack of real insight into what it means in terms of care in these Indigenous communities and how we might be able to serve better. So we're really excited with that. We've been working also with the Indigenous transition facilitators. So they're funded by Indigenous Services Canada, and they're doing an amazing job too in some of the communities in Ontario to really bridge the gap between acute care and care in the community, and really starting to sort of gather up an inventory of all the services that are available in community for folks, and how can we make those connections through HCO. So thank you for asking that question, and that's something we're really excited about this year. I hope that answers your question.
All right. I think you've answered Arnie's question.
Yeah.
Are there any others from the floor? If you can enter them in the chat, and otherwise I'll just begin to say that, Shelley, we're really looking forward to continuing to work with you as a 2-in-1 system to determine the best way to both integrate our work and create a clearer service path for Ontarians. I think we certainly are already part of those conversations at a local level with many, many OHTs across the province, but I think it's really helpful to have you here and speak to sort of what that provincial vision is for the future of the Health Connect Ontario service. So thank you again. I'm not seeing any additional questions, but I would encourage folks, if you do have follow-up questions, I would be happy to make sure they get to Shelley following today's session.
Thank you, Karen, and thank you, everyone. Totally happy to answer any further questions, and looking forward to working together moving forward on this. Thank you.
Thanks again, Shelley.
Thanks.
Okay, so we're going to move right into our next session, and certainly this is very much aligned with the information that Shelley just shared with us around the work of the Ontario Health Teams. In particular, we are going to hear from Pam Hillier and Sarah Grace about the work they're involved in South Georgian Bay OHT, and really how the role that 2-in-1 is playing, and how the capabilities of the team in Central East is being brought to bear in that partnership. So I will let them speak to it, because they certainly speak very well to the subject, and have done many presentations to OHTs across the province to share their insights from this very innovative work that they're doing. So without further ado, I will hand over to Pam Hillier, who is the Executive Director of Community Connection, our 2-in-1 Central East service provider, and the Health Initiatives Lead for Ontario 2-in-1 Services, as well as Sarah Grace, who is the Project Manager of the South Georgian Bay Ontario Health Team. So I will hand over to you, Pam. Please take it away.
Thank you, Karen. My slides up here. 1 second. Get in the right spot. Okay, so I'm assuming you can see that okay, Karen? Okay. So Sarah Grace is going to be joining in a few minutes, so hopefully I won't get too fast and out ahead of her. So I'm really happy to be here to talk a bit more about our work with the Community Information Exchange and the partnership with Community Connection and our South Georgian Bay Ontario Health Team. So Sarah Grace will be talking more about the Ontario Health Team in a few minutes, but Community Connection is an anchor partner in the South Georgian Bay Ontario Health Team. I'll try not to use acronyms. For us and other anchor partners in the team, we have the privilege to be a co-designer of this new model of care we envision for the communities in South Georgian Bay. And the term anchor partner is used purposefully in Ontario Health Teams as it describes the non-hierarchical relationships of the team. The team has worked hard to establish a foundation of genuine partnership and trust, and Community Connection is considered an equal partner with physicians, the hospital, and other organizations, which is really unique in our work in the community. So just to give you a sense for us, we're one of the 6 partners in Ontario, and a little arrow there showing where we are on the shores of beautiful Georgian Bay. So Community Connection's been around since 1969, and contrary to popular belief, I have not been there that long, but almost. We foster relationships with people and organizations to respond to social issues and inspire change. And this chart just gives you a sense of some of the work we're involved across many sectors in our region. So for more than a decade, 211 San Diego has been leading the development and design of community information exchanges. And the Community Information Exchange collective impact model aligns with the structure of Ontario Health Teams very nicely. And Sarah, Grace, and I appreciate the opportunity to speak about our journey. I just want to acknowledge our colleagues at 211 San Diego for their leadership and generosity in sharing their knowledge, tools, resources, and best practices for community information exchange model development in Canada. And the real purpose for us for the Community Information Exchange is really for that connection between social and community supports that Shelley spoke to in that chart, if you remember, is we have a unique opportunity to really develop that connection in a really positive way. So this is the image. This image shows a Community Information Exchange in a simplified form. So you can see that across the top there are to be involved in a community information exchange, you need a network of partners. And for a network partners, we have to have a shared language, a resource database, and bidirectional referrals, and a technology platform for data and data integration. And those 4 areas I'm going to speak to shortly, but all of those combine to provide the opportunity for community care planning and really around collaboration and cross-sector data sharing to create healthier communities. Right now in Ontario, we have a lot of health information exchanges, and they enable doctors, nurses, pharmacies, and other health providers and patients to appropriately access and share patients' vital medical information. And adding a community information exchange to this enables hospitals, health centers, and other care providers, social service providers, housing providers, maybe schools, and among other community resources to appropriately access and share data to improve care coordination and improve health outcomes for people. It's really important to note that a CIE is not a specific technology. It's not a generic one-size-fits-all solution. It's not intended to solve one issue, but is for the entire system of care. A CIE is not led by one organization, nor is it the direction dictated by the outcomes of one sector. It is not centered around institutional goals and interests. So this is a shift for all of us in the healthcare, particularly when we're an equal partner as a hospital with a lot of influence and capacity to really help guide the work. And a CIE really is developed to cultivate trust in the capacity within the community. It's to drive system change. A CIE is a community-led collaborative, and it's designed to uplift communities and those populations who experience disparities and inequities. And equity is a core tenet of a community information exchange. Now, how we kind of got on this journey I'm going to talk to. So there's a powerful body of evidence that shows that poverty puts patients at higher risk for cardiovascular disease, diabetes, depression. Children in low-income families are at higher risk of low birth weight, mental health problems, asthma, malnutrition, injuries, and hospitalization. And we did some work a few years ago, actually it was with Karen, around the poverty screening tool being developed by the Centre for Effective Practice and the Ontario College of Family Physicians. The screening tool was for primary care to use key questions to assess their patients' living situations, understand their current benefits, and include links to key government and community resources to support the positive interventions. And the goal then was for physicians to ask the questions, educate the patient, and then intervene and connect. You'll see 211 is one of the primary links on these screening tools. These are really multiple page tools, so I'm just put a little snippet here for you to get a visual of it. But in most cases, physicians don't have time to spend to do this education, the intervening, and connection. So in South Georgian Bay, with the work here, our primary care did adopt the screening tool, and instead of taking time to assess the patient's living situations and that, they receive patient's consent and send a referral form to Community Connection for one of our navigators to contact the patient. The visual on the right is kind of the process we developed. So over time, we developed an outcome report on the results of our intervention, and the report is faxed back to the referring clinician, and it's scanned into the patient's chart. So this process, these steps of 1 to 5, may take a long time. In some cases, our navigators are following up for many weeks on patients, particularly those in really vulnerable or complex situations. And we close that report and send it back, all by fax right now. So this referral partnership has increased to 10 family health teams, 3 hospitals, and 3 regional paramedic services. And we're able to connect about 50% of these patients to additional services and supports. And in Simcoe County, particularly, we're able to demonstrate that a reduction in repeat calls to 911 that are not emergency. So we're having some really good measures and some good impact on folks. However, closed-loop referrals and faxing, we have good patient outcomes, but workflow disruption. So our current technical infrastructure supports a high-volume inbound contact center. Our current tools have limited ability to structure adequate case notes that are needed to support follow-up activities and case coordination. This technology limits the ability to effectively schedule the volume of outbound calls required for closed-loop referrals. Privacy and security protocols require extra admin steps. And we've created lots of workarounds requiring cut and paste steps and administration burden. And as a result, we have poor workflow and reduced capacity because we'd really want to expand closed-loop referrals with other partners, and we're really limited on our ability to do that within the current environment. So back in 2019, we were able to get some funding through a federal project to contract a digital innovation solution company to help us define our business requirements. Like, what the heck did we really need to solve all these problems we were having? And it was really focused on the requirements that we needed for digital technology that would streamline our workflow. Just in Community Connections office is what we were focused on back then. We wanted to be able to enable that end-to-end referral management, notification and intake management, scheduling tools for outbound calls. I mean, we have so many referrals that multiple navigators are having to make our follow-up calls with patients they haven't talked to before. So really important that our data and our tools can help us effectively do that. We want to have more enhanced data collection and reporting and dashboards for managing the program overall. So we were able to define the business requirements, and then later that year we were successful in receiving funding through a collaborative project funded by the United Way Simcoe Muskoka to develop this product, this digital platform was what we were calling it. And this is where our digital journey actually began. Over time, though, we identified the need to develop new processes and tools used by our community navigators to improve outcomes for inquirers and patients. So vulnerable is a term applied to many populations. It could be racial or ethnic minorities, children, pregnant women, elderly people, prisoners, migrants, refugees, people who are homeless, people who use drugs, and people who have medical conditions like dementia, acquired brain injury, autism. And vulnerable people are more likely to be impacted by trauma and shame. And so we're really, in our shop, developed some tools to really embrace our trauma-informed principles, just to be aware of the prevalence of trauma and how common it is for all people, and recognizing the signs of traumatic impact and how survival stances may show up in people that we're serving. And one of our common challenges are that we'll do a follow-up call and the patient still hasn't followed up with the referrals we gave them, or they decided that they didn't need to do that anymore. So it's really just understanding and being engaged in taking steps that avoid re-traumatizing people. For example, a senior who's struggling to make ends meet, and we've convinced them now that they can access a food program in their community, we may offer to have a three-way call and connect them to the program that offers that food program, rather than just giving out a phone number where they have to tell their story again. So just starting to change, or we have changed how we process various typical ways we answer our calls, but just adding in these elements. We've also included these stage of change assessments to help guide conversations, to really figure out where that person is in their stage of change and how can we determine what barriers there are or opportunities for that individual. And the focus for us is not to convince the person to change their behavior, but to help them move along the stages of change and embrace the services that are available to them. And then the practice of empowerment conversation skills at the right time are really important. And we're really able to show how effective these activities are. And during these activities, we collect detailed data, which is helpful to support the households that are in complex situations where multiple follow-up calls are needed. And the data that we collect is also useful for their healthcare provider to understand their patient's living situation. The other elements, other additional challenges we've identified with the process is really our traditional referral process. Right now, the client carries all the weight of the next steps and access. It's not trauma-informed, so clients have to describe their situation repeatedly to different people. The lack of ownership, the client easily falls through the cracks. We can give them, if they don't follow up and we can't get a hold of them, we're not able to help them. Organizations that we're referring to or receiving these referrals start from scratch, so the benefit of the details we've already learned are determined by our community navigators. And then our anonymous service delivery, it relies solely on the client to self-report, and clients in crisis or risk may not be good historians. One example that happened to us was we had a family that had a very tragic situation happen, and when our team looked at what happened and how we ultimately failed that family, it turned out that family had called 7 times to 211. Each call handled effectively and appropriately, but because our navigators couldn't see the connection between all the calls, we ultimately failed that family. So that lack of data, it wasn't our service that wasn't good. It was really just that missing piece of how we collect and use the data to better serve people. And so we can't right now, with anonymous service delivery, can't view that client history or their status changes. And it really limits that holistic understanding of their situation, like that family I just spoke to. And it also limits our ability to support case coordination or goals and prevention work as we're moving people along that stages of change process. One of our solutions was to develop a new longitudinal record. And right now we're just in the final stages of testing. I feel like I've been saying that for months. But we received funding in 2020 through United Way, Centred Canada, through the Emergency Community Support Fund. And through the funding, we're able to develop this new longitudinal record. And it really will connect all our call reports for each client so that we can then see if they've called before, how did we help them before, those kinds of things. It guides more detailed data collection, so we can be very specific and have more streamlined and more workflow processes on the data collection side, and have more drop-down lists and pick lists, so we can really be more improve our data collection and standardizing our data collection. This tool connects with our existing legacy systems, so the current technology we're using now, and it will also connect with the end-to-end referral management system that we're currently building as well. So just one of the other tools being developed with by 211 San Diego is called a comprehensive social continuum assessment, formerly known as a risk rating scale. And this has been a really exciting area of our work to really dive into and understand the value of this tool in our information and referral environment. It's really to serve as a common language to understand the complexity of social influences on individuals. And it can also be used with other approaches. If we're looking at advancing racial equity, for example, there's different ways we can use this tool as we're trying to move along our journey of improving our equitable services. The goal of this tool is to holistically capture the comprehensive needs of an individual and track the change over time. The next slide gives you a little visual of what this tool looks like. So it really is an assessment tool that it determines the immediacy of a client's need along the 14 domains at the top in the blue. And it establishes a baseline risk to measure that change over time. And this example where the red arrow is pointing is using housing and home safety. So for example, if a caller or a referral came in and it was someone at risk of housing, we would ask specific questions, and then the tool would determine what level of risk is that person. Are they in crisis or are they vulnerable? And it actually connects to our taxonomy in our database of the services available for that risk assessment. So it's really smart in that it's effectively tied to the services and that we would refer them to. If a navigator was to use the assessment of all 14 domains, we understand it would take about 10 minutes or so. And the value of choosing one or more of these assessments is that when we do a follow-up call, we do the assessment again, and we can see if that individual has moved from crisis to critical. Were they safe and they're now vulnerable? So we can actually measure the impact of our service and the connection to other services on their well-being on this scale. And earlier this year, we received additional funding through a federal project to purchase the tools, materials and questions, responses, the scoring and the algorithm, and guidance from the team at 211 San Diego. So right now we are working towards the business requirements that will include this assessment tool in that call report I spoke to earlier. It's really exciting work, and I think for our United Way partners, this kind of tool, for example, every 211 could maybe assess callers for a month on income or transportation for a certain region and produce that data in real time. I think it has really powerful opportunity to really get a picture of the needs of our communities and the different types of impacts or social risks that families are coping with. So the big piece of work that's underway right now as part of this community information exchange is the development of a longitudinal record that we'll use for coordinated care planning. This is just an example or a sample of a part of one from San Diego. And it's really comprised of data from multiple partners. So we envision in our Ontario Health team, various partners will contribute data on the same client into this longitudinal record. The data collected by different service providers stays in their system. No one's changing technology, but we're really just using the Community Information Exchange to collect the data in a single longitudinal record of all the services in the community for each patient. This record is stored in our CIE's Azure cloud, and partners' credentials would allow tiered access to view all are part of this record. So health agencies are not sharing health information. This is all the other demographics, household information, the other services in the community they're accessing, and in that yellow box are those risk ratings that I just talked about from that assessment tool. So it would enable all of the care providers in our community to access a whole picture of how all the community agencies are supporting that patient or that household, and help just really with their care planning. We can see what services they're receiving or not receiving. Right now we have, our Ontario Health Team has a number of committees that are working on the various elements that we need for this longitudinal record to be created. So we'll be happy to share the learnings as we move along in defining those various elements for this data sharing. And I'm hoping Sarah Grace has arrived. Are you there, Sarah Grace?
Yes, thank you, Pam.
Okay. Over to you, Sarah Grace.
Good morning, everyone, and thank you so much for the opportunity to present today. As Pam mentioned, my name is Sarah Grace Bebenek, and I'm the project manager here for the South Georgian Bay Ontario Health Team, or OHT, which is one of 51 approved Ontario health teams in the province, working together as a collaborative team to plan and deliver a coordinated continuum of care for our attributed patients. And as you can see on the slide, our patients primarily live in the areas of Collingwood, Wasaga Beach, and Clearview. Our Ontario Health Team was developed based on a long-standing history and partnerships from across their community. And our formal community consultation to develop the Ontario Health Team began back in 2019. And since that time, continued consultation across our community with organizations, governors, patients, families, and caregivers has resulted in the development of our co-designed strategic framework for our OHT. Next slide, please. So based on consultation and community involvement to date, the following strategic framework that you can see here has been developed, as I mentioned, in co-design with our partners, governors, patients, families, caregivers, and those that live in the community. This framework informs our activities over the coming years, the principles by which we work together as an OHT, and essentially is our framework for implementation, measurement, evaluation, and funding allocation. The operational work conducted by our Ontario Health Team backbone support, led by myself and action teams, is guided by our implementation plan, connected back to our Ontario Health Team milestones, responsibilities, and building blocks. This plan has served and continues to serve as a foundational co-designed framework for our decision-making and project planning to advance our common goal and shared purpose across organizations for a healthier community. Importantly, including the physical, mental, and the social determinants of health. As you will see, one of the key priorities of our Ontario Health Team is digital health and innovation, which supports the development of innovative integrated systems to provide holistic access to care for our entire population. Next slide, please. As indicated in this diagram, as Pam mentioned, to execute our strategic priorities, the appropriate action teams have been developed using a shared accountability and distributed leadership model to foster authentic collaboration across our partners. The success of our teams to date can be attributed to our strong relationships with our community, supporting agencies, and organizations from across health and social care. Each of these teams has a specific terms of reference and work plan, which has been developed by the committee to implement and evaluate their work to continue to accomplish our framework's priorities, objectives, and to support our priority populations. The presentation today will focus, as you know, on the work of our Digital Health and Innovation Action Team and our collaborative project with Community Connection to integrate and connect health and social care. Next slide, please. So more specifically, the South Georgian Bay Digital Health and Innovation Plan aims to achieve the following objectives that you can see on the slide. With the presentation today really focusing on numbers 3, 4, and 5, as specifically we'll outline how our collaborative project with Community Connection through the Ontario Health Team will ultimately better connect new and existing digital and virtual health systems and social services to enable data sharing and collaboration. It will deliver innovative and equitable population health-based solutions. and develop improved data collection methods to better understand our population's health needs and address health equity barriers. And ultimately, it will improve business intelligence and resource data to inform policies and programs within our Ontario Health Team. Next slide, please. So through the Ontario Health Team Digital Health and Innovation Action Team, the CIE project has decided to utilize the Ocean e-referral network through an investment that connects the provincial e-referral software with Community Connections SQL database. This connection will enable clinicians and community partners to make electronic referrals into Community Connection, or 211, either through a patient's chart or through the web portal. Through this process, patient referral information will be sent securely and electronically, and it can be linked with the patient's physician if selected and the patient provides consent. That way, the patient and the physician are continually updated about the status of their referral. So let me walk you through an example. So a referral can be sent through the Ocean e-referral by the patient's primary care provider or from a community organization such as the local YMCA. Once that referral is received by 211 through the electronic solution, the referral information is automatically translated into 211's referral and data system. 211 then contacts the patient based on the identified concerns by the initial referral and develops an outcome report based on that conversation with the patient including the resources that the patient is connected to. This outcome report is then sent back to the primary care provider if consent has been received, and that happens regardless if the referral came from them or came from the community. So they are notified of the patient's social determinants of health needs and really start to provide the wraparound services and care. And based on service trends, the 211 digital infrastructure can then evaluate gaps in available services in the area, which can then come back to the Ontario Health Team to inform our future program planning and development. Next slide, please. So just at a high overview, this slide outlines what it looks like on the e-referral software to initiate the referral into 211. So you can see here that the system has identified the local catchment area, and then we hope that through the Ontario Health Team model, we'll be able to spread and scale this project to serve all of Ontario. Next slide, please. Ultimately, the goal of the Community Information Exchange Collaborative is to improve access to 24/7 coordination and system navigation services and improve the health and wellness for individuals and populations through a holistic health equity focus. A focus of the work of our Ontario Health Team is to work together to reduce health inequities in the health system. And health equity is truly created when individuals have a fair opportunity to reach their fullest health and well-being potential, including the social determinants of health. There's many causes of health inequities related to the social and environmental factors, as you would be aware, including income, social status, race, gender, education, and physical environment, which we are working to address through the CIE collaborative. In South Georgian Bay, we plan to improve health equity through the Ontario Health Team by developing relationships with local groups, working on community safety and well-being, situation tables, and justice initiatives, and the homeless coordinated access systems. As a result of this collaborative community information exchange project, we can redesign care pathways for our most vulnerable population using a population health management approach, facilitate coordinated transitions and communication between providers, reduce inappropriate variation, and implement best practice standards for equitable access to services and provide services that better enable access, seamless transitions, and coordinated services. Next slide, please. So okay. I think, go ahead, sorry, go ahead, Pam.
I'm sorry, Sarah Grace. Thank you so much for the presentation. And I'm not seeing yet any questions in the chat. So while we're waiting for that, I just want to say that we really appreciate the time that you've spent both today in coming to present to the group, but also the time that you've spent over the years in really developing out what this could look like for 211, but also for the people who make those connections to services. And We are continuously inspired by the work you're doing and always looking for how we can support, how Ontario 211 Services can support the expansion of these concepts into other Ontario communities. We do definitely envision, the development of the tools that are required to expand this work provincially, as well as, securing and enhancing the tools that we have today. So we really, truly appreciate your efforts, and we look forward to continuing to learn from the evaluations that are taking place of this work that you're doing.
Thanks, Karen.
Thank you very much. I appreciate it.
And Pam and Sarah Grace, can we offer to people that if they have follow-up questions that they can reach you directly?
Absolutely. More than happy to.
Yeah.
Thank you so much.
Thank you.
Really appreciate your presentation today, and it's such exciting work. Onward and upward. All right, thank you again. And our next presenter again is, it's a very exciting partnership that has been in development for a little while now in the City of Toronto, a partnership between Findhelp Information Services, our 211 Central partners, and the City of Toronto. I won't get into the details of it. I'll let them describe the project and the work that they are doing there that is obviously focused on some very significant priorities for the Toronto community around mental health access, and in particular mental health crises. So I want to introduce to you Angela Finateri, who is Director of Community and Organizational Impact at Findhelp Information Services, 211 Central, and Mo Shuriye. Do I have the pronunciation of your last name correct?
Shuriye.
Shuriye, thank you, Mo. And Mo's Manager of Policing Reform, Social Development, Finance and Administration at the City of Toronto. So I will hand it over to the two of you to share the exciting updates around this Toronto Community Crisis Service.
Thank you, Karen, and so pleasure to be here with you all today. I've called in just to make sure that my audio is working, so apologies if you're seeing a phone number talking instead of my face, but I'm also have my video on. Yeah, so I'll begin really at a high level, just sort of describing this exciting collaboration with Findhelp Information Services 211 and the City of Toronto and our community anchor partners, how this initiative came to be, some of the role of the Toronto Community Crisis Service, and then what's really ahead of us going forward. And Angela will talk a little bit about, from the 211 perspective, how the partnership has been and some of the key major change initiatives required to help support this work. But I think we have to begin with what really initiated this work, and so for me to sort of ground you to what happened in June 2020. So if I could have the next slide, please. You'll all likely remember that in June of 2020 there was considerable protests, both here at the City of Toronto, but also across many jurisdictions in Canada and internationally, responding to the murder of George Floyd, but responding to more broadly calls for reform around policing, the role of police in our society, highlighting other deaths of citizens that have had interactions with police, such as Regis Paquette, Chantal Moore, Mr. Shaduri, Mr. Saga, and many others, and asking, can we do this differently? Do we need to be responding to what is perhaps a public health issue with a law enforcement response? Can we think about doing this differently? And so it's really on the heels of that conversation that City Council adopted in Toronto 36 recommendations for reform, and with a particular focus on finding alternative responses, community-led responses. And really the next slide, I sort of want to walk you through what was the basis of that work. Begin with sort of acknowledging that there are certain facts that we have to acknowledge. One being that the mental health treatment and a broader community social safety net has been underfunded, period. It's been underfunded for the past 20 to 30 years, and people have fallen through the cracks. And there have been less supports available for people, and therefore police have been responding to calls for persons in crisis. We've seen those calls increase over time, and unfortunately we've put the police at the forefront of what is really a public health response. And as I said, instead of having and this has put instead of having a public health response, we've had a police response, and this has really put particular risks for people who are Indigenous, Black, and equity-deserving communities. So it's with that residents, communities, and organizations called on the City of Toronto to reimagine a non-police response, to do extensive consultations, which we did in the fall of 2020 into 2021. So in the next slide, I just wanted to highlight to you some of the ways we engage community in informing the pilot that we eventually launched. So we did 33 community roundtables, and remember, this is the beginning of the pandemic, so this is largely done virtually. Some of it was done in person. We partnered with 17 community organizations to do these conversations with their service clients and others, and they provided their feedback to the city. We did 2 public surveys. We engaged 29 subject matter experts, and then we did a public opinion poll. And then on top of all that, we also create opportunity for people to do their own community engagement discussion guides and to submit their feedback. And then we create an alternative community safety accountability table with 50 plus different community organizations informing the city with monthly meetings as we were crafting the model. And we did a review of 53 different crisis response models from across 50 jurisdictions and distilled all that into a report that we gave to City Council in February of 2021, where they adopted the approach that we pushed forward. I'll synthesize what we heard at a high level at the community consultation. Number one, whatever alternative response has to be community-led and community-based. Number two, that there was significant trust and collaboration that needed to be created to do that work. And number three, that there had to be significant resources put to help ensure that these models were sustainable and were well-resourced. We couldn't do this on the cheap, is what we were hearing from community at a high level. Those are some of the feedbacks we received. So moving forward in the next slide, we proposed a 3-year pilot, what we call the Toronto Community Crisis Service, to run a community-led crisis response in 4 areas of our city that will respond to non-emergency calls for service for mental health and substance use, and send trained mental health clinicians to respond instead of sending the police. The pilots launched in March of 2022. We had our first one up and going. It's part of a 3-year pilot, and the goal is, if it's successful, to scale up and do across the whole city. And it's one of our key actions under the SAFETO, the city's community safety wellbeing plan. Some of you may be familiar with this, but each jurisdiction is required under provincial legislation to have a community safety wellbeing plan, and the thinking behind it is to broaden community safety to be more than just a police question. It's a community question about how do we each engage with what community safety looks like. So what's the model and how does it work at a high level? If I can have the next slide, I'll walk you through the model. It really, the city is really just there as a backbone support. Again, going back to the key principles, what we heard, this being community-led and community-based, we are there to do intergovernmental advocacy in terms of any gaps in services, to do public education around the new pilot, and to ensure that we can identify areas for increased community investments. A key partner has been 211, Findhelp 211, being our access and intake. Now, the one thing that we also heard from the community consultations is people said they don't feel comfortable calling 911. And if we were to build out any new crisis response service, there would have to be an alternative for them to reach that service, because there was a fear that by calling 911, they will still get a police default response. So that was a key feedback we heard, particularly from communities who've experienced barriers in the past. So really partnering with 211 made tremendous sense, and leveraging that portal and that access point as one access point was critical. We are partnering with anchor partners, so the city isn't delivering the service directly. It's being delivered by trusted community organizations on the ground in the areas, so working with a partner, who we call an anchor agency, to hire the teams, manage the teams, roll out the teams. In terms of the pilot teams, they're going to be composed of multidisciplinary staff who have different backgrounds: nurses, health, harm reduction specialists, people with experience, peers, and so on and so forth, but at a minimum to respond to crisis calls. We also highlighted that we have to evaluate this pilot to ensure that we're learning and being iterative as we learn and incorporating the changes we are hearing, but then also that we're able to build on what we're learning. So we have partnered with the Provincial System Support Program at CAMH to do our third-party evaluation, and we will actually be receiving from them in November a 6-month report on some of the key learnings that we can take. And last but not least, it was very critical that there would be community involvement at all stages, both the development of the pilot, but also the implementation. So each of the pilot sites have a community advisory table that informs their pilot, but overall, in terms of the broader steering committee, we also have a pilot citywide community advisory table that is composed of subject matter experts, residents with lived experience, various different other community leaders, including not-for-profit, the Ontario Health Team, and others, to help inform the development of these pilots. So this is how it works at a high level. And as you can see, collaboration is a key component of this work. If I can have the next slide, I'll walk you through the key features of the service. So what does the service actually do? When it's fully implemented, it's going to be 24/7. Right now, we have 3 out of 4 locations that are 24/7. Again, we've been active since March, and so we're going to be 24/7 very shortly. It's voluntary and consent-based, so the teams have no ability to apprehend or force the service upon anyone if the individual declines the service. That is part of their right, and we respect that. And as long as there's no immediate harm to them or others, that ends the interaction. The service is for clients who are above the age of 16, and each of the various different sites have partnerships with other referral partners, including Strive Toronto and others who could help support any clients who may be under the age of 16. Key component has been around ensuring that the pilots are trauma-informed and have a harm reduction approach to how they serve clients. I talked about this earlier in terms of ensuring there's no wrong door. So residents can reach the service by calling 911, and the call will be diverted, if appropriate, to the mobile teams to respond. But most importantly, they can reach the service without calling 911. They can call 211 directly, or they can also call the community anchor partner directly as well to reach the service. The service involves the dispatching of mobile crisis teams. And the last 2 I really want to highlight, which I think are the secret sauce of this service, which is the post-crisis follow-ups and the system service navigation. So I think a significant challenge is with the law enforcement approach, the officer is there to resolve the incident and then move on to the next incident. They do not have the time or the capacity or the resources to follow up with this person the next day, help them navigate various different systems if they need help with housing, if they need help access to food, if they need help with access to healthcare. This is really the importance of this pilot, is that with the partnership with 211, with the partnership with our 4 different community anchors partners, we are able to help navigate people through different systems and help connect them to the supports they may need, so that most importantly, they don't fall back into crisis, and that they're able to be connected to the services they need when they need it the most. And that also includes culturally relevant services. So by partnering with 4 organizations who have a great track record on the ground to do this mobile team, and 211, we're able to connect people to services that may be able to be most aligned to their cultural experience, be they Indigenous, Black, newcomers who have specific language needs that they may have, which only reduces the barriers to getting the right services they need. The next slide, please. As I said, the pilot is geographically based. We chose 4 areas to first test this out. I'm not sure how familiar you are with the geography of Toronto, but it's 4 different areas: the Northwest, the Northeast, the Downtown West, and the Downtown East. We have 4 different partners, and I'll talk a little bit about these partners and their experiences. Just of note, the call volume is the highest in the downtown for mental health related crisis and substance use crisis. And these 2 pilots we knew based on police data would likely be the busiest, and they are the busiest based on calls made to 911. And the Northeast and the Northwest pilots, we chose those areas due to police data on mental health apprehensions. So apprehensions seem to have been higher in those areas. And we also noticed that in the Northwest, there was no current mobile response already existing in that area, so it was a bit of a service gap, and that was another reason why we chose the Northwest. And last but not least, another key consideration of these pilot areas is demographic diversity. So in terms of larger newcomer populations, Black and racialized populations in the Northwest and the Northeast, which is part of the reason why we chose these areas. If I can have the next slide. I really want to highlight, I know I said the secret sauce was the post-crisis follow-up, but really I should have said the secret sauce is the 4 partners who are, and our partner 201 who are doing this work. The 4 partners, what they bring to this work is that they really bring a locally responsive implementation. Again, hearing from community that they wanted collaboration and they wanted trusted organizations, it was critical to do this work with organizations that they were familiar with, that within their community, that knew, that has been serving their community. So we partnered with, in the Northeast, to deliver the service, Taibu Community Health Center, which has been a community health center in Northeast Scarborough with a particular focus on serving Black communities, Francophone communities, Indigenous communities, and newcomer communities. And in their work in doing this, they are running a service partnership with 7 others, including Hung Folk Mental Health Association, as I said, STRIDE, CMHA Toronto, CAMH, Scarborough Health Network, Scarborough Center for Health Communities, and Black Health Alliance. So each of them bring various different referral pathways and different partners to this work that is unique to their geographic area. So depending on what the client's needs are, they're able to refer them out to a different agency to help support that. Gerstein in Downtown East is no stranger to many of you, has been doing this work for 30 years, has been running a mobile crisis team for 30 years, has tremendous crisis response experience, so it made sense to naturally partner with them. And in particular, the work the lens and the strength that they bring to this work is that peer model of ensuring that it's strengths-based, non-medical approach to this work. They bring a strong referral pathway, as you can see, including Toronto North Support Services, Uni Toronto, Wood Green, and many others. We've also partnered with an Indigenous-led partner, Two-Spirited People of the First Nations, who's doing the pilot response in Division 14, the Downtown West, and they are doing this work with 2 partners, the Nightby Indigenous Youth Agency and Parkdale Queen West. Last but not least, the Canadian Mental Health Association of Toronto, who is doing this work in the northwest area of our city, and brings within a referral partnership of 7 different partners, including 2 community health centers, Rexdale, Black Creek, as well as the Jane and Finch Center, Yorktown Family Services, CAFCAN, and Addiction Services Central of Ontario. So I just want to highlight these 4 partners who respond to all calls within their catchment area, but really bring different strengths to this work, different communities of trust, and a lot of communities that have been traditionally overrepresented in policing have high distrust of the city and other institutional parties, and that really these partners are helping us break down those silos and ensure that we reach out to people and connect them, most importantly, to the services that they may need. Have the next slide, please. So the glue that holds us together is 211, and so I really want to acknowledge the importance. I'm not going to go over what 211 does because you all know that, but I want to just sort of highlight that Sue, Gasol, Angela, Dave, my 3, Shuriye have been just amazing and have been champions of this since day one. I think the importance of the role of 211 in this work is that 211 serves as both access, facilitator, enabler, and I think also capacity builder. We've been able to resolve about 15% of calls for service on the phone and connect people to support that hasn't required an in-person visit. Not all calls will require an in-person visit, but some will, and that has been critical. But having a low barrier way to access the service has been tremendous and is very important to the capacity of this work. And supporting our locally responsive partners has been critical. And I don't want to steal Angela's thunder, but she'll go into a little bit more of that in a second. Last but not least, I want to just conclude with sharing with you some of our high-level program data. This really just, in the next slide, you'll see, this is some highlights. This is from July. So you'll see that in July, we received about 549 calls. But as of today, we just surpassed 2,000 calls last week. So this sheet that I'm showing is a little bit outdated. We haven't yet designed something that's fancy, so I will be sharing in November updated program data, and I can come back or share them with Karen to distribute to you all. But I think really the key takeaways that I want to show is really on the right side, which is the call diversion, which is, let's remember the principle, why this all started back in June of 2020, which is communities saying we need to do this differently. We cannot have a police response or a public health response. And the fact that 87% of all calls transferred from 911 did not require police involvement is a major data point. And that 15% of these calls were supported by 211 over the phone. 9% of calls did lead to some people requiring a visit to emergency room. And the ambulance were in attendance at 3% of calls. These were only requested by the teams at 2% of calls. And then the bottom part, the connection to community-based services, 23% of clients accepted referrals or additional support, and 47% requested a follow-up from the team within 48 hours after their incident. And 70 were at that time connected to post-crisis case management. And so this is really about the transformative work. In conclusion, I just want to highlight this transformative work from the city's perspective would not have been possible without the willingness and the championing of partners like 211 and our 4 community anchor partners to want to trust and work together to do this service, to serve residents. There's a lot more learnings to be had, but it's a really exciting start, and I think I've taken up a lot of space, so I'll stop and let Angela also throw her presentation in. Oh yeah, there's further resources available. That's the last slide, my apologies.
Okay, thank you, Mo. So I'm just really going to go into really about our readiness. And so when we were approached about the Toronto Community Crisis line, obviously, you need to, sorry, I forgot to share my camera. Sorry about that. So when we were approached in terms of the Toronto Community Crisis Service, clearly the first step was to get our own organizational readiness. Like, what were we able to do and what did we need to do to become ready? And so, first of all, one of the things is that we wouldn't have been able to even begin, as Mo said, without the strong relationships. So Findhelp 211 Central has been a part of the City of Toronto's mental health strategy. We had pre-existing strong relationships. We sat at the mental health strategy table during COVID. So some of the key partners, such as the Gerstein Center, the Canadian Centre for Mental Health, Taboo, and the Two-Spirited Peoples, we were all there during COVID working together. So it was really lifting that team and moving forward to support the initiative. Also looking at our own team internally, our service navigators had been experienced in handling many complex mental health calls from vulnerable populations in Toronto, but during the pandemic, I would have to say that when there was hardly any resources at the very beginning, I think every other call was a mental health call. So really, we were already making referrals and already reaching out to our community partners for help. Our team, as many of you know, are AIR certified community resource and information referral specialists. But on top of that, we also had to get them ready and management, harm reductions, assist training. These were some of the trainings that we had to either repeat for some of our existing staff, but also on board and with the support of the Georgian Center, get all of our staff up and ready during the launch. Then we also looked at our existing infrastructure, our technology, our systems. So having our database of resources, the telephony, our information management tools, and the ability to be able to report. These were all of the critical elements that we had in terms of our systems readiness. And this is what made us, be able to launch and support the initiative without having to worry too much, because there was a lot to be done in the upcoming months. So next slide, please. So what did we have to develop? Well, obviously the first thing is that, when we were first approached and Mo kept saying, you need to do a dispatch. And I'm like going, dispatch? What does dispatch look like? And it really, because, our team has been trained to answer calls, to provide referrals, but dispatch is a little bit more complicated than that, in the sense that, you're getting referrals, and many of them right now in this first phase are coming from 911. So our staff are getting referrals from 911 who have already assessed the call to be appropriate for the pilot. So what they will do is they will provide a referral to us. We need to then ask certain questions, such as obviously, the location. The 911 operators do ensure that the call is appropriate by ensuring that the person is safe, that there are no weapons present, and that it is an environment whereby the crisis team can then respond. But there's also a code-led response, which is, sometimes the police will call and they'll say, they would like to attend, but they think that the work would be best done by one of the crisis mobile teams. So, and then also when the crisis team are out in the field supporting, the situation can change. So what will happen is they might call back or radio in to say we need backup because the situation that we came to has now escalated and we need support. So we needed to develop this whole call flow to make sure that whether calls are coming in from 911 or even calls that we ourselves at 211 identify as being appropriate for the pilot, that we ensure that, there is a process for handling calls and redirecting them back. In addition to that, we also had to, customize our call report. So our intake form had to change quite drastically. So some of the things that we do not do in iCarol, for example, we don't ask environmentally safe questions so an environmental scan was an important piece of this work. So once the call, the police refer the call to us, we then ask them for an ID, which is an event number, and that event number really ties the call from 911 to 211 to the crisis teams. So if we ever had to go back, that event number ties that whole call together. So from the time the police called to the time that our navigators did the assessment to the time the crisis team went out on the field. So basically what we get is an event number, and then we will then do a very quick second assessment, if you will, and that is really to ensure, once again, because sometimes what the person in crisis is stating to the police may not necessarily be what happens when one of our service navigators begin with the call. So what we're doing is just really taking down, more information. And then through our iCarol, we actually have a direct link that goes into a dispatch portal whereby all the referrals are then sent to the crisis mobile team. So the crisis mobile teams, through their iPads or smartphones, they're able to see, here's a dispatch, here's a location, this is what the call is about. They'll know that, basically general information about the caller, but also that it's safe to attend if there's any other persons available in the house or wherever they're attending. And then this information all gets transmitted over to them. When this information then gets transmitted, our team then has to get on a radio, which is to really radio the crisis team. So if the call, for example, went to Taboo, our team would then get on the radio to inform the crisis team, the Taboo team, that we've just sent you a dispatch, and please look at the dispatch portal. And so that also was work that needed to be developed, as well as you can imagine there was a lot of training, whether it was training on how to use the new portal, cross-training with Toronto Police Services, because there's a lot of different lingo that we all had to learn, and in addition to how we then, sent the referrals over to the crisis team. Next slide. So the key impact. So as Mo stated, obviously we've received already over 2,000 calls. 85% of those calls led directly to a dispatch to the crisis mobile team. And most of those calls were actually, persons in mental health crisis. So, and the reason, many of them are from persons in mental health crisis is because 911 at this time is actually diverting most of the calls to us. Our navigators are also now fielding appropriate calls that, if they have a mental health call and they're speaking to someone, they might then say, this person, especially if they're in the pilot area, then they will refer it over to the crisis team. And the calls that do not go to the crisis team, what ends up happening is that they're either handled by phone, which is then our team would then do those follow-ups. So any call that our team has handled that did not go to dispatch, we will then do a follow-up with the caller to ensure that they got the help that they needed. There's been a lot of positive response from the community. In fact, when we do get calls, if anything, more people are wondering why this service isn't available outside of, the pilot areas. So our navigators are well equipped to make referrals to other community-based led organizations in mental health to be able to provide that service. And once again, these calls that come outside of the pilot area, our team would then do a follow-up call to ensure that those individuals got the help that they needed. Clearly, as Mo stated, it's, we would not be able to do any of this work with the strong partnership and collaboration with the anchor agencies and the City of Toronto. And really, the biggest collective impact and effort is the pilot, to get the pilot off the ground, was all those hours and all those meetings that we had with Mo and his team. We wouldn't be here today without their great leadership. So it's it takes a lot of effort, and it takes a lot of people. So it's been a really positive pilot in the sense of our working relationship with the anchor agencies in the city. And next, please. So what are some of our learnings? Well, first of all, Findhelp, all of our team. I think this is one of the pilots, when I look back, that really involved every aspect of our organization, from the launch to the implementation to maintaining this pilot. We had every, whether it was our service team, our data team, the technology, human resources. There was a lot of hiring that we had to do, and onboarding and project management. So literally, I don't think anybody at Findhelp was not part of this project. There are many lessons learned using the radios. Like, our staff are learning new language every day, like 10.4, 10.6, and and really having and also I guess the backup even to the crisis teams, that was the part I think that all of our staff had a little bit more anxiety, because sometimes, as you know, when you go out on a call, the call may not go as initially intended, and then when they had to radio back for, you know, to us to get backup, I mean, those are things that make those calls really stressful. But at the same time, you know, right now, if you go back and ask the service navigators, you know, from March till now, there had been so many learnings, and now for them it's second nature. We're also exploring now the idea of, you know, currently our model is really a blended model, so everybody on our 211 team does answer or the trauma crisis line. However, we have a priority setting, so we have a designated team in terms of, well, when I say designated team, is that there's certain team members that are, those are the calls that they would take first. However, our whole entire team answers these calls. And future, you know, is whether or not we need to look at more of a designated, just a team for the Toronto Community Crisis Service. And the other thing is really always revisiting our protocols, our procedures, because they are always changing in terms of, we want to always make sure that we have the best crisis response available to those that need help, and always revisiting our practice to ensure that we are always available 24/7 to support. And I guess the last piece is to say that, you know, I believe, Mo, it's in November, where we are doing some, where we'll be promoting in the pilot areas, the 211 as the front door to the Toronto Community Crisis Service. So we'll have more lessons.
Thank you so much, Angela and Mo. I really, really appreciate your presentation today. We are just past noon, but I did notice that there are a couple of questions in the chat. If you had a few moments to address them, we'd appreciate that. And the first was from Lauren, asking about any challenges in getting buy-in from other frontline providers at the outset, and if you can speak to any lessons learned in that regard.
Sure, I can start. You know, it was helpful that we did that extensive community consultation in the fall of 2020, because that really helped provide the community goodwill and interest in this project. And then when we did a call for partners in 2021, we really had a great response. So we really didn't have hesitation from partners who said that they could do this work or they want to do this work, and we are really happy to have the partners that we are working with. So we haven't had that type of hesitation. Certainly it was new for 3 of the 4 partners in the sense that Gerson already had a crisis team, and so Taigu and CMHA and Two-Spirit had to build it out, so there's a bit of a learning curve. And certainly, as Angela shared as well, for 201 to do the dispatching was different, but you know, beyond those early learning, there wasn't you know, any major challenges beyond that.
Thanks. Thank you, Mo. And as many have commented in the comment section, the numbers that you've presented thus far are truly amazing. I think, you know, an 85% diversion rate from 911, especially for those public health issues, as you mentioned, Mo, is pretty phenomenal. So lots of eyes on this, as I know you are well aware. We're watching in interest. We look forward to learning from you, and you know, as you go forward, would appreciate any thoughts you have on what are the considerations for 211 to look at playing this role in other communities. How can we structure it? What are the must-haves from a 211 perspective to play a part in these initiatives? And then, you know, from a tools and technology perspective, how can we make sure that we're best positioned to enable or activate this work at a local area across the country, or sorry, across the province? So I do appreciate your time, everybody's time today. The presentations were all fantastic. And it's really exciting to think about how our 2-on-1 work will evolve over the course of the next several years. So again, appreciate you all being here. I'll throw it back to Barbara if she'd like to have the last word and close off our session today.
Karen, thank you. And I'd like to say a heartfelt thanks to our speakers today, Shelley, Pam, Sarah Grace, Angela, and Mo. These three presentations reinforce innovation in action and the importance of partnerships for us to deliver better outcomes for Ontarians. And the fact that these pilots are indeed scalable across the province, there are some powerful opportunities that are in front of us together. So I want to reinforce that we at Ontario 2-on-1 Services, we applaud these local pilots and anticipate support and expansion of these types of concepts across the province in future. Again, I think that brings our AGM to a close. I would like to thank everybody for participation.